Good morning. I'm Eamon Anderson, Director of Acumen America. We invest in early-stage companies serving low-income Americans across health, financial services, and workforce development. Our health investing is focused on Medicaid innovation. And with the crises facing this country, we're excited to bring together entrepreneurs and Medicaid leadership to forge new partnerships and address the urgent needs of so many. Over the last few months, our country has seen a health system stretched to the brink, and even as heroic efforts have made gains in the fight for public health, we're left with historic unemployment and social unrest. As protests in response to the killing of George Floyd persist, the nation is being forced to confront the disparities that exist within our criminal justice system for people of color. Many in this movement are calling for needed policing reform, but we must also work to tackle racial disparities in other systems that have been broken for far too long. COVID-19 has had a disproportionate impact on Black and Brown communities, highlighting systemic inequities in health access and quality, and making the need to transform our health system even more urgent. In Louisiana, African Americans account for 33% of the population, with 70% of COVID deaths. In Michigan, African Americans account for 14% of the population and 40% of deaths. And in Chicago, 30% of the population and 56% of deaths. In 42 states, Latinx communities make up a greater share of confirmed cases than their share of the population. In 8 states, it's more than 4 times greater. The COVID-19 crisis has disrupted many aspects of our lives over the last few months, but it will also change the landscape of our work for years to come. In this time of change, we have an opportunity to reimagine healthcare for our most vulnerable patient populations. And this community of Medicaid leaders, entrepreneurs, and investors must lead the charge. The solutions you will see today were selected by a committee of healthcare investors, advisors, and strategists, and all have exciting solutions to support payers and providers in meeting the needs of Medicaid patient populations in this changed world. Our hope is that this series of conversations over the next 2 weeks will launch new partnerships between entrepreneurs, health plans, and state leadership to adapt to our new reality and build the healthcare system we need. On behalf of Acumen America, the Center for Healthcare Strategies, and Adaptation Health, we appreciate your time and look forward to this fantastic conversation.
Thanks, Eamon, and thank you all for participating in this event. I'm Stella Tran, Senior Associate at Acumen America, and will be moderating today's panel and webinar. I'm excited to be joined by 3 great panelists today, Andrey Ostrovsky, James Schuster, and Jared Augenstein. Before we jump into today's panel, there are a few housekeeping items I want to highlight. So we'll have this 30-minute panel discussion first, followed by the company presentations. Each of the 4 companies presenting will have 10 minutes to present, followed about 5 minutes of Q&A. Please feel free to send questions via the Q&A function on Zoom, and we also have questions that have been provided in advance by the expert panel. And with that, I am going to jump into the panel. So for the first question for our panelists today, how would you characterize the opportunities and challenges you're seeing among Medicaid members in access to care pre-COVID and now? And how are these challenges impacting both access to maternal health and behavioral health services? I will start first with you, Andrey, then over to James and Jared.
Sure, thanks for having me, and I appreciate the question. In terms of challenges pre-COVID, I think that a payment differential between what Medicaid providers get and non-Medicaid providers get is a really important consideration for us to have, and with the caveat that it's rare that there is a Medicaid-only provider. I mean, most providers take multiple types of insurance with the exception of, let's say, like home and community-based services. That issue has been perpetuated, unfortunately, during COVID, and even in this, if we can call it aftermath of COVID, even though COVID is still rampant and accelerating in certain states, as evidenced by the fact that we've had legislation now in place pushing for distribution of relief funds to Medicaid providers, and it was only, I believe, yesterday that HHS started to respond and actually effectuate some of those changes in providing that financial relief. I sit on a couple of boards of services businesses that are largely Medicaid reimbursed, and both businesses nearly went under. And had they not had very compassionate investors that were willing to double down and put in more capital just for the sake of these consumers continue to have access to care, these businesses would have gone under and likely created a pretty big void in their communities. If we add tech on top of it, which creates complexity in selling into the healthcare ecosystem, distributing innovation in the healthcare ecosystem, solutions that are targeting primarily Medicaid populations are, again, much more disproportionately impacted. For example, a solution that's trying to sell into employers is a lot easier to sell before COVID and during COVID than a solution that's trying to sell into some aspect of the Medicaid supply chain. And I believe that that gap has only been exacerbated during COVID. It's also an opportunity, I think, for really progressive plans, health systems, mostly plans, in some cases pharma companies, to double down and invest, with the very important trend that commercial numbers are going down and those consumers are going over to the managed Medicaid products. I'll pause there and see if Jared or James have anything to add there. James, are you unmuted?
Yep, I'm unmuted. Thanks. Yeah, thanks for laying that out. Just to give a brief context, I work with UPMC in primarily in Pennsylvania, and the Pennsylvania Medicaid system's actually, compared to most states, well funded. And we've also had a really innovative and interesting model in which behavioral health services are actually managed typically by the human service departments in each county. So we've had really an early model of medical and social integration of medical services, in this case, behavioral services and social determinants of health. So we've actually had good access of Medicaid members to behavioral health in Pennsylvania historically. Our, what people call the penetration rate, the average use of behavioral health services by Medicaid members, at least in the counties that Community Care, a UPMC company, partner with, is typically in the 20 to 25% range. So the use of services has actually been relatively high. What we've seen as the primary challenge has not been people accessing services in total. And actually in Pennsylvania, at least in the behavioral health side, the Medicaid rates are often better than commercial and Medicare rates. So it's not actually getting people to use services, but really getting people engaged, and this is true for both medical and behavioral, but getting people engaged in really preventive care and kind of ongoing management as opposed to acute service utilization. So really a lot of our focus has been on developing strategies to keep people engaged in community settings and to really support them outside of facilities. The biggest challenge, I think, I'm sure we'll talk some more about this with regard to COVID, is clearly there's been a large move to telehealth. And clearly, you know, people with less means are less likely to have broadband access and even sometimes less likely to have a device on which they can readily access the internet. And even when they do have a device, they often have limitations on their data plans, which make them reluctant to use online services. So we've seen that as probably the biggest challenge at the moment, working to try to preserve access for Medicaid members. Although we've had reasonably good success so far. The decline in service use over the last few months among behavioral services is less than we've noticed with other medical services, and a lot of that is related to telehealth use, especially payment for telephonic only services.
Yeah.
So I'll stop there. Let Jared chime in.
Great. Yeah, and I can pick up on the telehealth thread there, James, in your comments. I mean, to me, the biggest opportunity that's emerged from this, you know, amid all of the challenges, has been that telehealth is finally having its moment. And I think in many cases, digital health more broadly is finally having its moment. In Medicare, we've gone from about 11,000 Medicare members per week accessing telehealth services to now we're over 1 million on a weekly basis. And we're seeing similar, you know, 100x increases in the commercial world and in the Medicaid world too. And that's really exciting. I think it also introduces a new set of challenges and a new set of access challenges in particular. As James talked about, there's sort of the digital divide for patients where we still only have about 75 to 80% of Americans have access to high-speed broadband internet, leaving tens of millions without access to broadband internet, which is basically a necessity unless you're doing phone-only telehealth. You have a significant chunk of the population without a smartphone. You have a lot of instances in which people don't speak English as their first language, and a lot of telehealth services are only provided in English, or the app's only built in English, or the patient portal is only offered in English. And so there are language issues too. And I think on the provider side, there's a similar sort of digital divide. Andrey noted that there hasn't been a lot of funding that's gone to safety net providers as part of the stimulus package. And that's made it hard for smaller providers, which have been hit particularly hard, to buy the necessary technology that's required to offer digital health and telemedicine services, to get the necessary software in place, to get the hardware that they need. And so I think that the digital divide sort of exists on the patient side and on the provider side, and it's probably particularly exacerbated in a Medicaid population. And then I think another challenge is that you have a real patchwork of policy across states. So from a sort of company perspective, if you're thinking about trying to provide a service to the Medicaid population, what may be the case in one state is different than the next state is different from the next state. And so it can be really challenging to understand sort of what the policy landscape really is across all 50 states, what services are covered, what services aren't covered. And all of that's changing really rapidly. There's been a lot that's been put in place on a temporary basis. And now I think states are going through a process of figuring out what they want to make permanent and how they want to revise their telehealth and digital health policies more broadly. And just keeping track of all that can be a challenge, much less figuring out sort of what your business model and how that relates to the payment model in that state.
Thanks, everyone. And thanks, Jared. That's actually a really great segue to our next question, which is around Medicaid policy. So how might recent Medicaid policy changes impact maternal health coverage and access during and post-COVID, and what's here to stay? And would love to hear the same for behavioral health. So Jared, could you kick us off?
Sure.
You want me to kick us off? Sure. So, I think that it's important to sort of start with the overall context here, which is that state budgets are going to be more constrained over the next, let's say, 2 to 3 years than they have been in a really long time. At the same time that the unemployment rate is at an all-time high and an increasing number of people are going to be shifting into or newly eligible for Medicaid coverage. So I think it's the overall sort of state economics and Medicaid program economics are really challenging. I think that at the same time, states are realizing that telehealth can help solve access issues and can be a really critical tool in ensuring that patients can continue to have continuity of care, especially during pandemic time, but even not during pandemic time. And so I think that tension is, I don't know how that's going to play out, but I think that's going to be a really key sort of tension to watch. If I had to do a little bit of crystal ball gazing, I would say that where we land in 6 months or a year from now in terms of telehealth policy in particular is going to be that we have more coverage than we did pre-COVID, but maybe not as expansive of coverage as we have now, which is really pretty broad for most payers and in most states.
Yeah, and if I could chime in there, there's regulatory levers that have been put in place which technology companies or tech-enabled services businesses can exploit right now, in particular for behavioral health. So in January pre-COVID, there was a state health official letter that provided some clarity to states that, in fact, behavioral health issues, in particular those for kids or folks under 21 years old, that previously it was up to the state to interpret what really qualified as a mandatory early prevention screening detection treatment benefit. And CMCS basically said, per the Support Act, if there's a behavioral health issue and it has anything to do with a kid, you must cover it. And that creates a tailwind for innovators or traditional service providers in the behavioral health space, especially in adolescents or kids. So that's one. There's interesting legislative proposals right now that if companies or participants on this webinar want to go do something and create tailwinds, the HEROES Act proposed one thing that was really helpful for the entire space, which is an FMAP increase, and that hopefully the Senate will adopt. I think they will. But there's also some interesting language that I don't believe was in the HEROES Act, but the Senate could very well put in place, which is having a similar to what the Support Act did with a 100% FMAP for state Medicaid IT innovations being put out that have to do with behavioral health. Well, there is a proposal to do something similar with COVID-related state Medicaid IT build-outs. Again, 100% federal match. And I think that there's enough gray room and kind of depending on the progressiveness of each state, that a savvy technology innovator could go into a state Medicaid program and say, hey, we are a module for your state Medicaid IT program. And that's a little bit more of a big data play. I think that perhaps a little bit out of scope for most of the companies on this specific call. Maybe Quartet a little bit could like plug into that. And so those are really interesting tailwinds that we could all be advocating for. And then finally, to what Jared pointed out with like 1135 waivers that will eventually expire, Seema Verma just yesterday was quoted as saying, we can't go back to what it used to be with telehealth. And yet in the same webinar, she said, well, yeah, but we don't know if that means we're going to have payment parity or to what extent between telehealth and in-person visits. And even she acknowledged appropriately that we will need a legislative fix to this, but she referenced a need for a legislative fix in the context of rural reimbursement. I would say that we actually need a legislative push to mandate to CMS that in fact there is payment parity, but then let CMS issue the regs. I fear that if we don't consolidate our advocacy efforts, CMS may get distracted by other things and not in fact promulgate regs beyond 1135 waivers. And this huge tailwind that I think our beneficiaries are benefiting from is going to go away. So it's up in the air right now, and we can play a role. I don't know, James, if you have any thoughts on that.
Yes, no, I agree. Clearly, what we've noticed is for both maternal and behavioral, there have been, clearly the number of in-person visits has gone down, partly of anxiety related to COVID and being in medical settings, but also, practical issues that are associated with the economic impact, increased challenges with transportation, decreased bus service, decreased childcare, and so on. So tele has been really important. And, it seems to us that this hopefully has been a tipping point event for tele. We actually had parity at UPMC Insurance Division. We actually had parity in place in payment for tele as well as in-person visits and with in-person visits. And there was still pretty modest uptake until the COVID pandemic occurred. So I agree, certainly additional legislation and other regulatory support of this will be important. You also asked about, some other approaches to engage people in care. And we've really tried to take a broad approach to engaging people in care in terms of making sure people get screened for depression in primary care settings. We've created a online system by which our PCPs can refer people for behavioral health interventions. And we've had a really robust telepsychiatry program, particularly for Medicaid members, to really support rural providers with psychiatric services for their patients. So we think that all those interventions certainly have been helpful in the past, but there will certainly be continued opportunities for growth, we think, post-COVID, particularly if the regulatory emphasis on, persisting and supporting growth of both tele and digital innovations is present. We're about to launch a digital tool for depression and anxiety for all of our members, including those in the Medicaid products. And we think that that'll be a nice additional strategy to get people engaged in care.
I think one of the, just to want to focus in on something that Andrey said too about the limitations that CMS has around creating its post-COVID telehealth policy. So there, and this was very confusing because there were changes made in various different stimulus bills that gave CMS flexibility to waive certain requirements during a period of public health emergency. But the two of the, or three of the most key changes that were made, in order to sustain them permanently, new legislation is required. And so that's sort of that telehealth can be provided outside of rural settings, which is really key. The second is that FQHCs and RHCs can be eligible distance sites. And the third is that CMS expanded the list of eligible providers who can provide telehealth services. There are others, but to me, those are sort of the three biggest. The FQHC and RHC one is especially critical. Once the public health emergency ends, we're going back to a world in which FQHCs and RHCs cannot serve as the distance site for telehealth, meaning if a patient's in the home and they want to connect to their FQHC or RHC provider, they're not going to be able, the FQHC and RHC aren't going to be able to get paid for that. That's really, that's really critical. And I think that's sort of one of the most critical changes that really needs to be sustained, especially in the context of this conversation, both for behavioral health services, for maternal health services, and just broadly.
Yeah, this is James. Just one additional comment in follow-up to that. One of the things that we've noted is that to some degree in Medicare, but especially in Medicaid, there are a number of patients who connect using telephone only, because of the challenges they have in terms of not having an adequate device or having data limits. So I think continuing to pay, have telephone only be available for payment, as well as potentially looking at funding to help supplement additional data limits for Medicaid members would both continue to enhance growth of the telehealth platforms and access.
Thanks, everyone. And so now on to our last question. So what is the role of plans and state Medicaid agencies in scaling and sustaining efforts to address the challenges that we've discussed? And what are the areas that feel most ripe for innovation with respect to both maternal health and behavioral health access? And this question is for all three panelists. And Andrey, can I have you kick us off?
Sure. I'm trying to think, how can I be professional in my remarks, but still genuine? Well, I'll put it this way. We have some health plan leaders like James who have a deep compassion for the consumer. We have other health plan leaders that are really coming to work every day to optimize for EBITDA. And we need more Jameses out there. However, I'm not sure that we're going to fix that problem quickly because that requires a whole retooling of how we train leaders. What I think can be done in a little bit quicker fashion is as damn fast as possible, moving away from fee-for-service and moving toward as much globally capitated risk as possible. And I think that shift would require a fundamental reimagining of the role of a health plan. And the reason why I'm very carefully choosing my words and trying not to get too fired up is that the opposite end of the spectrum of the Dr. Schusters of the world is, I had a company that I'm on their board, and I had to go to a health plan regional president who didn't respond after some gentle nudging to say, hey, your lack of reimbursement per this required fee schedule is causing this provider to not be able to see patients, which in turn is leading to a backlog, which in turn leads to very significant morbidity and possibly mortality. And that plans, when I finally got to the chief medical officer, their response was like, can you just remind me exactly how many people and the dollar amounts? I'm like, no. This isn't a dollar amounts issue. This is you're killing children or you're not killing children. And I want to, as quickly as possible, move away from an individual decision-making process around utilization management and how do we tweak 5% up or down around the margin in a fee-for-service environment, and instead introduce as much, ideally full risk as possible to the provider and have them make a ton of money by doing the right thing. But then that puts into question, then what's the role of a health plan? And I think that's an interesting discussion to have. And I think there's really interesting innovators out there that are kind of helping usher that transition. So that's kind of where I'll leave things. And if we have time, I'm happy to elaborate on that.
Yeah, this is James. Just if I could make a comment, since I was noted very kindly, thank you. You know, I take only, I appreciate the kind thoughts, but you know, one of the reasons that or the primary reason probably we've been able to do what we've been able to do around behavioral health in Pennsylvania is really support and leadership from the state Medicaid program. You know, all the Medicaid plans work for a state Medicaid agency. And there have been kind of incentives and goals set by the state to really encourage access and, you know, provide incentives for plans to meet targeted goals. In Pennsylvania, like I said, because of our county directed model, the incentives for plans are typically supplemented and enhanced by county input. But I think, you know, there's people, as we know, as payers, people respond to incentives, you know, and that's true for plans as well as providers and members. So I think there isn't, it's, you know, I have to confess, my perspective is limited to Pennsylvania. It's where I've been my whole professional life, but it sounds like implied from a national perspective, there are opportunities elsewhere for states to enhance incentives around these themes. I think the other efforts really to continue to focus on are really, one, continued enhancement around access, second, continued support for telehealth and digital tools, and the other theme, which we haven't talked about much today, but I think is opportunities to really enhance integration of services, both to make sure that behavioral health is addressed in medical settings, or at least that behavioral health needs are identified there. You know, and there are even payment mechanisms available using collaborative care codes or other value-based payment strategies to support that. And also to make sure people with serious mental illness get their physical health needs addressed when they're and identified by their behavioral health providers. So I think there are lots of large themes. You know, clearly the tele-technical piece is impacted by our current crisis, but there's still many opportunities that were there before, and paths are still available now to continue on.
Yeah, and you know, I really agree with everything that Andrey and James said. I mean, just to sort of piggyback on a couple of themes. One, on this, the ridiculousness of the fee-for-service system has been, you know, particularly highlighted by this crisis. Seeing payers, whether it's states or commercial plans or Medicare, just the volume of guidance that's required to construct coverage policy that's coherent for digital health services, it's, you know, it's insanity. And so I do think that the only way out of that is some sort of fee for value, I think. And I agree with Andrey that, you know, I'm all for moving to that type of payment model as quickly as possible. I think the reality is that the entire healthcare system is going to be very risk averse over the next year or two, just given the economic realities. And so, you know, it's a good time to be thinking about transitioning to value-based payment as quickly as possible. I hope it, you know, it happens as quickly as it can. I'm scared that it won't. A couple other points. I think, you know, state Medicaid agencies can pay for telehealth, and they can pay for, you know, remote patient monitoring, and they can pay for e-consults, and they can pay for chronic care management services, and all of that provides sort of fertile ground for innovators to come in and develop care models that address physical and behavioral health issues. I think one of the sort of areas that's ripest for innovation is I think we've seen that, 100% in-person care is not ideal, 100% virtual care is not ideal. And so I do think that there's, and I'm sure we're going to hear about this in the second 30 minutes, but there's a really big opportunity in my mind for companies that can really come in and fundamentally from the ground up rethink how to deliver the best care possible, integrating the best of in-person care where you're building personal relationships. Some things just have to be done in person, and the best of virtual care where you can have more frequent communication, you can interact with people in their home where they're more comfortable, you can remotely monitor different physiologic indicators. And I think the digital health companies that have been most successful have started to do that. I think we're still sort of in the really early innings of the potential for true innovation there.
Great. Thanks, everyone. I wish we could continue this conversation. We only had 30 minutes slotted, but really appreciate everyone's insights today. So with that, we'll move into the company presentations.